Good afternoon, everybody. I'd like to begin by welcoming you all. Thanks a lot for coming to see my presentation today. My presentation is based on a breast cancer case that I got to see while in my placement in histology. First of all, we'll look at some population statistics regarding breast cancer. The breast cancer is the most common cancer in Australian women. Breast cancer is the second leading cause of all cancer-related deaths in women in Australia. Over 15,000 women will be diagnosed with breast cancer by the end of 2014. However, it's not all bad. The successful public awareness campaigns that have been over the years have an improvement of treatment techniques have raised the survival rate from 72% to nearly 90% over the last 25 years. The two common types of breast cancer are the invasive ductal carcinoma and the invasive lobular carcinoma, with the invasive ductal carcinoma being the most common one. Now, the invasive ductal carcinoma originates in the duct, as the name says, while the invasive lobular carcinoma starts in the lobules, and the lobular cells become abnormal and fill up the lobules with the cancer cells. Now, having a look at our patient, she was a 73-year-old Caucasian woman. She had no previous history of any cancer. She came in for a mammogram, which had found a suspicious lesion in her left breast. She later came in for an MRI, which has confirmed the suspicion of a breast cancer. Now, she came in and they decided to operate and to remove the cancer. However, this lesion was too small to palpate, and they had to use a hook wire biopsy technique in order to remove the tumor. With a hook wire biopsy technique, a hook wire is guided by X-ray and inserted inside the center of the lesion, so the surgeon can know exactly the central location of the lesion. Now, two specimens were removed in the surgery. One was the breast cancer tissue, and the other one was the central lymph node, which is quite important because the central lymph node is the lymph node that's closest to the lesion. They inject the dye into the lesion and see where it follows, so therefore any metastases are likely to come to your central lymph node first, and then able to be spread through the body. Now, the specimen A was a fibrofatty piece of tissue that was measuring 60 by 52 by 35 millimeters. It was inked to provide orientation, which is quite important. The inking allows the surgeon to go back and excise more material in the future if any of the margins were found to be positive for cancer. The specimen was seriously sectioned in 12 slides from medial to lateral in the sagittal plane, and then cut into 30 pieces and all embedded in 30 cassettes. The specimen B came in as a fatty piece of tissue measuring 20 by 10 by 6 millimeters. In the process of sectioning, a single lymph node was found which measured 9 by 4 millimeters. It was sectioned into 5 pieces and all embedded into one cassette. Now, all the specimens were fixed in 10% neutral buffer formalin and embedded in paraffin. Then later, they were sectioned using a rotary microtome and stain with the following stains. The hematoxin, ER, HER2, icahedron, and CKAE1, AE3 stains. We'll have a look at the staining now, and from this medium power shot you can see the lesion. Basically in this slide here you cannot see any of the normal architecture of the breast tissue. There are no lobules or ducts that can be seen in this picture, and the cancer cells are presenting with monoculous polymorphism, which means that they are different from the cells that they have originated from, but they look similar to each other.
Managers will be dishing up the lights until 2 o'clock. Please come along tomorrow.
Now, if we take a closer, higher magnification look at this tumor, we can see the classical Indian file pattern, which is quite distinctive of the lobular cell carcinoma. As some of you may know, the breast tissue has a very low mitotic rate and grows very slowly therefore. In this picture here, you can see a mitosis and possibly another mitosis here, which can be used as a useful tool in diagnosing cancer, because in cancer the mitotic rate increases significantly. Now, this is a low power shot of the excision margin. On top of the region you can see the inking that was done in the cutout room. Also, it is quite important that there is no cancerous abnormalities that are seen anywhere in this shot, which was also the case for all of the excision margins, which means that the biopsy was quite successful and was able to remove all of the cancer. Now, this is the ecadherine membrane staining. It stains the ecadherine transmembrane protein and is quite useful in differentiating between a lobular cell carcinoma and a ductal cell carcinoma. A ductal cell carcinoma usually stains positive for ecadherine, while a lobular cell carcinoma stains negative for ecadherine. In this case, we can see that our patient sample is negative, which also supports our theory that this is a lobular cell carcinoma. Alright, in this slide here, we can see the estrogen and the progesterone receptor staining. They're quite important because if they were positive, they allow treatments options for the clinicians to use to treat the cancer and avoid using chemotherapy. Now, in the estrogen receptor staining, we can see that greater than 95% of the cells are displaying a strong nuclear positivity, while in the progesterone receptor staining, they are also greater than 95% of the cells are showing moderate to strong nuclear positivity, which basically means that the estrogen receptor staining is more positive and is likely to be used in the case of treatment. Now, the HER2 staining is negative in this case, therefore the patient is unlikely to benefit from the drug called Herceptin. Now, the in situ hybridization was also sent away to another lab and it came back negative, supporting the look of the stain. Now, I'd like you to take a special look at this positive control as it is one of the best quality stains in Australia. As some of you may know, our recent QAP review has scored 5 out of 5, And in fact, it was so good that they have requested our staining protocol in order for other labs to be able to achieve similar results. Now we have a look at the sentinel lymph node, and in this H&E stain, we cannot see any impression of morphology of a secondary lobular carcinoma. Now, if we have a look at the CK-AE1-A3, it is negative for any broad spectrum cytokeratins, thus supporting the impression of the morphological impression of no presence of secondary lobular cell carcinoma in the central lymph. Now, just to sum up this case, this lady is extremely lucky to have the things turn out the way they did. Everything went right for her, starting from the surgical team doing an exceptional job and making sure that the excision had all the clear margins, which means that all the cancer was removed. She had no metastases in the sentinel lymph node, which means that the cancer did not have the time to spread and metastasize in any other part of the body, which is most likely the way it happened. Now, the fact that she has positive estrogen and positive progesterone receptor staining gives the clinician an option to treat her with endocrine therapy instead of the toxic chemotherapy. Therefore, this lady is likely to be released from the hospital by now and sitting at home having a cup of tea, enjoying her life completely free from breast cancer. Now, we'll take some questions, but before we go, I'd like you all to take a special note of this right here.
Happy birthday!
Questions?
How old are you?
27 today.